We developed tabulated illness scripts for effective clinical reasoning during an OSCE, or Objective Structured Clinical Exam. We took on this project after noticing a disturbing decline in the pass rates across all OSCEs. Starting to take a look with the United States Medical Licensing Exam Step 2 clinical skills, we see in the upper left-hand corner that examinees from US and Canadian schools in the year 2004 had an overall pass rate of 96%. Those same examinees in the bottom left-hand corner in the year 2017, or 13 years later, had a pass rate of 94%, a decline of 2%, or about 400 students not passing. In the upper right-hand corner, we see examinees from non-US and non-Canadian schools in the year 2004 had an overall pass rate of 83%, and those same examinees in the bottom right-hand corner in the year 2017, or 13 years later, had a total pass rate of 73%, a decline of 10%. Taking a look at the COMLEX Level 2 PE, we see in 2017 the pass rate was 92.7%, and in 2019 the pass rate was 91.7%, a decline of 1%. For the GMC UK PLAB Part II in 2005, the pass rate was 68%, and in the most recent years, 2018 and 2019, the pass rate was 66%, a decline of 2%. So we see across the board, OSCEs have a decreasing pass rate. And this is all going on despite advances in medical education. We have self-directed learning, all the multiple choice clinical vignette questions, UWorld and question banks, instructional videos, YouTube or Sketchy, team-based learning, small group sessions, problem-based learning, including the text-based cases or traditional methods people use to prepare for the OSCEs, and earlier clinical-based learning, including preclinical doctoring programs or preclinical ward programs. And even now, the assessment-based learning, or the integration of the OSCE into medical school curricula in the junior years 1 and 2. So this all begs the question, are our graduating physicians today less clinically skilled? Our research question is, can a script-based learning model, tabular organization of illness scripts, provide a superior preparation to the traditional methods as previously mentioned for effective clinical reasoning during an OSCE? Clinical reasoning is the cornerstone of an OSCE. The Liaison Committee on Medical Education defines it as the integration, organization, and interpretation of information gathered as part of medical problem solving. Script theory helps provide direction to the integration and organization tenets of clinical reasoning. Lubarsky writes, "Our brains interpret the world by comparing the attributes of the mental models it creates with the features of an actual scene, checking for consistencies and discrepancies, patterns and irregularities. When a perfect or close fit exists between the attributes of a mental script and the details of a real-world scene, interpretation occurs quickly, automatically, and effortlessly. For example, in a restaurant script, one expects to perceive food, waiters, and cutlery. The mind is not a blank slate each time it enters a restaurant." Applying script theory to medicine gives us illness scripts. Lubarsky writes, "According to script theory, medical knowledge is bundled into networks called illness scripts that allow physicians to integrate new incoming information with existing knowledge, recognize patterns and irregularities in symptom complexes, identify similarities and differences between disease states, and make predictions about how diseases are likely to unfold. These knowledge networks become updated and refined through experience and learning." The implications of script theory on medical education are profound. Since clinician teachers cannot simply transfer their customized collections of illness scripts into the minds of learners, they must create opportunities to help learners develop and fine-tune their own sets of scripts. A critical goal in medical education, then, is to help learners acquire the necessary building blocks for constructing suitable representations of the numerous and varied situations they are likely to encounter, and to ensure that those concepts are strategically linked to facilitate retrieval in the proper clinical context. Viewed in this light, script-based education is a concept-forming, link-building enterprise. Fundamentally, script theory places knowledge organization rather than generic problem-solving skill as the foundation of clinical reasoning. Taking a step back and exploring the illness script in Feltovic and Barrows in 1984 defined the general knowledge structure as having three components: enabling conditions, faults, and consequences. Enabling conditions are contextual and patient background factors, most similar to the social history, that influence the probability that someone gets a disease. Examples of enabling conditions are age, sex, medical history, current medications, risk behavior, hereditary factors, occupation, and living environment. Enabling conditions contribute to the fault or the pathology that constitute the biomedical core of a disease. Faults may give rise to certain consequences, complaints, signs, and symptoms. Classically, the enabling conditions of elderly male with consequences of constant substernal chest pain may trigger the illness script for an ST elevation myocardial infarction. What about the course, diagnosis, frequency, and treatment? Custers writes, the heterogeneous nature of the category suggests that it is not, as a whole, a natural part of the script structure. Some items may actually be part of one of the other script components. For example, knowledge of the course of a disease may be regarded as knowledge of possible future consequences and may be included in the illness script component. Knowledge of frequency of occurrence, to the extent that it plays a role early in the diagnostic process, may be captured in the illness script model by the role of the enabling conditions. For example, a physician will be more inclined to activate hypotheses about malignancies for older patients and for younger patients, even if frequencies are small in any age group. So essentially, information about the course, diagnosis, frequency, and treatment are components of the original enabling conditions, faults, and consequences. Returning to these enabling conditions, faults, and consequences, Custers explains, the biomedical details of the fault do not play an important role in the diagnostic process, particularly in routine diagnostic situations. In diagnostic situations, less experienced participants often have trouble recognizing a certain constellation of enabling conditions and consequences, i.e., they fail to activate the appropriate illness script and have to revert to fault-based or biomedical reasoning to make sense of the features that confront them. Experts are better diagnosticians than novices because their knowledge is organized and structured in full-fledged illness scripts, with the enabling conditions and some readily available consequences providing the opportunity for a quick script activation. Lubarsky finalizes that studies of expertise development in medicine have consistently shown that those considered to be experts are distinguished not by their superior problem-solving skills, nor by their enhanced capacity for memory retrieval, but by the content and organization of their knowledge base, that is, by the set of individualized scripts they have acquired through learning and experience. Again, we see the centrality of integration and organization as tenets of clinical reasoning.